Hi, I'm Abby Phillips, and this is my second video going over the National Asthma Education and Prevention Program. Right, so, going over key clinical activities for quality asthma care. So, first, you want to establish an asthma diagnosis and determine that symptoms of recurrent airway obstruction are present based on history and exam. You want to look at their history of cough, recurrent wheezing, recurrent difficulty breathing, and recurrent chest tightness. Symptoms occur or worsen at night or with exercise, viral infection, exposure to allergens and irritants, changes in weather, hard laughing or crying, stress, or other factors. In all patients greater than or equal to 5 years of age, use spirometry to determine that airway obstruction is at least partially reversible. So, PFTs can be really helpful with diagnosing your patient with asthma, and then also consider other causes of obstruction. So, long-term asthma treatment. So, goal asthma control, reduce impairment, so prevent chronic symptoms, require infrequent use of short-acting beta-2 agonists, so your SAFAs, and then maintain normal lung function and normal activity levels. Then you want to reduce risk, so prevent exacerbations, minimize the need for emergency care, hospitalization, prevent loss of lung function, or for children, prevent reduced lung growth, and then minimize adverse effects of therapy. So long-term asthma treatment continued. So first, assess at each visit. So asthma control, proper medication techniques. So using your MDIs with spacers is an example. Written asthma action plan, patient adherence, patient concerns, obtain lung function measures by spirometry, PFTs at least every 1 to 2 years, more frequently for asthma that is not well controlled, just so you can help with their treatment. Determine if therapy should be adjusted. Like I said, maintain treatment, step up if needed, step down if possible, and then schedule up follow-up care. So asthma is highly variable over time. See patients every 2 to 6 weeks while gaining control, every 1 to 6 months to monitor control, and then every 3 months if step-down therapy is possible. So long-term asthma treatment continued. So use of medications, select medication and delivery devices that meet patients' needs and circumstances. Use stepwise approach to identify appropriate treatment options. So inhaled corticosteroids, also known as ICSs, are the most effective long-term control therapy. When choosing treatment, consider domain of relevance to the patient, so risk, impairment, or both, patient's history of response to the medication and willingness and ability to use the medication, review medications, technique, and adherence at each follow-up visit. So it's very important that your patient is doing proper technique for their medications just so that it is getting in their lungs. I've seen a lot of people that just figure out how to use their inhaler like at the hospital, even though they've already had one for so long. So that can be very important and help patients not having to go to the hospital for exacerbations. So asthma care for EIB, exercise-induced bronchospasm. Physical activity should be encouraged. For most patients, EIB should not limit participation in any activity they choose. Teach patients to take treatment before exercise. So your SABAs will prevent exercise-induced bronchospasm in most patients. Your LTRAs or LABAs also are protective. Frequent or chronic use of LABA to prevent exercise-induced bronchospasm is discouraged, but as it may disguise poorly controlled persistent asthma. Consider long-term control medication. EIB often is a marker of inadequate asthma control and responds well to regular anti-inflammatory therapy. Encourage a warm-up period or mask or scarf over the mouth for cold-induced exercise-induced bronchospasm. So maintaining asthma control through pregnancy. So check asthma control at all prenatal visits. Asthma can worsen or improve during pregnancy, so you need to adjust medications as needed. Treating asthma with medications is safer for the mother and fetus than having poorly controlled asthma. Maintaining lung function is important to ensure oxygen supply to the fetus. Your inhaled corticosteroids are preferred long-term control medications and remind patients to avoid exposure to tobacco smoke or also vaping as well. So managing exacerbations, home care. So develop a written asthma action plan. So teach patients how to recognize early signs, symptoms, and PEF measures that indicate worsening asthma. Adjust medication. So increase your SABAs, and in some cases add oral systemic corticosteroids, and remove our withdrawal from environmental factors contributing to the exacerbation, which could be many things. Also, not even just at home, but out in certain work environments, things like that, that can trigger a lot of things for people. So monitor response and then seek medical care if there is serious deterioration or lack of response to treatment, and give your patient specific instructions on who and when to call. So managing exacerbations for urgent or emergency care. So assess severity by lung function measures for ages greater than or equal to 5 years. You need to do physical examinations and figure out their signs and symptoms and treat them to relieve hypoxemia and airflow obstruction and reduce airway inflammation. So use supplemental oxygen as appropriate to correct hypoxemia. Treat with repetitive or continuous short-acting or SABAs with the addition of inhaled ipratropium bromide in severe exacerbations. Give oral systemic corticosteroids in moderate or severe exacerbations, or for patients who fail to respond promptly and completely to your SABAs. Consider adjunctive. Consider other treatments such as intravenous magnesium sulfate or Heliox in severe exacerbations unresponsive to treatment. So typically you'll start out kind of with your lower dose, your SABAs, and then progress from there if they're not responding well to those. So yeah. Monitor response with repeat assessment of lung function measures, physical examinations, and signs and symptoms, and in emergency department pulse oximetry, which can be important when determining your patient needs oxygen or not. And then discharge with medication and patient education. So tell them about medications, your SABAs, oral systemic corticosteroids, and consider using your ICSs if needed. Referral to follow-up care. asthma discharge plan and review of inhaler technique and whenever possible environmental control measures. Just making sure your patient avoid just try to help them avoid future exacerbations. All right.